والصلاة والسلام على رسول الله الأمين. I am Professor Ahmed Mitwalli, founder of the Society, acting now as the treasurer of the Society. I'm pleased and happy to be with you tonight. We have our webinars, which is a series of webinars that we started from last year. Tonight, we're going to talk about update in the management of hyperphosphatemia in patients with CKD. We are lucky and honored to have with us Professor Marcus Kettle, and also we are honored to have with us our colleague, Dr. Fuad Shaibi. So please enjoy the talk. All I would like you to ask from you, please, if you have any questions, please put it on the Q&A. Put it on the Q&A. We are not allowed to talk to our speakers or our moderators. Also, I just want to inform you that there will be 2 hours, CM hours, will be credited to you automatically if you already supplied us with your Saudi Council member. So please enjoy the lecture. Please, Dr. Fahd, take the floor.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء. I would like to thank Professor Ahmed for giving me this opportunity to be with great people tonight. It is my pleasure to introduce Professor Marcus Kettle. Professor Kettle is a professor of medicine and nephrology. He's a director of Department of Medicine at Robert Bosch Hospital in Stuttgart, Germany. Dr. Kettler has more than 200 publications in very well known medical journals, and he was the principal investigator in several clinical researches related to chronic kidney disease and metabolic bone disease as well. He was also the council member of the chronic kidney disease and MBD guidelines in KDIGO in the working group for several years. Today, after this long experience in chronic kidney disease and metabolic bone disease, he will share with us his such wonderful information and experience, and he will talk about the latest update on management of hyperphosphatemia in patients with chronic kidney disease. Thank you, Marcus, to be with us, and I hope everybody will enjoy the presentation. Thank you.
Thank you so much for your kind introduction. I will now try to share my presentation with you. I hope you can see it all. Is it present? Okay,
yes.
I don't hear complaints. So all of you have a very great evening. I will, as I was introduced, talk about hyperphosphatemia in the essence. And I will first do some update or some repetition of pathophysiology and regulation, then talk about the guidelines, and then add a couple of new aspects to this management problem. I always like to start a little with this unofficial KDIGO logo of the disorder that's called chronic kidney disease and mineral and bone disorder. That is now 15 years ago that this term CKD-MBD was coined. And this was done because before that area, we were talking about renal osteodystrophy, which is all about bone, but not so much about topics like vascular calcification or endpoints such as cardiovascular disease and mortality. And as we realized more increasingly that this is connected all together, it was necessary to go this new way ahead. Going back to the pathophysiology, on the left side of this graph, the, let's say, conventional or traditional way of secondary hyperparathyroidism development is shown. So in the time course of kidney disease, there is an under hydroxylation of active vitamin D, leading to low calcium levels, but also leading to an increased secretion of PTH. At this time, it was thought that serum phosphate also triggers PTH, but only late and only indirectly. The newer view is also now about 15 years old, 10 to 15 years, because it was found that before a lot of pathways like this happened, FGF23 starts to rise in the blood of patients, and then leads to a decrease in hydroxylation and activation of vitamin D, triggering the left pathway. But this hormone, FGF23, was thought to be very important and powerful to prevent CKD patients from developing hyperphosphatemia, so that in the lifespan of a human being, it seems to be of major importance to keep the serum phosphate levels as normal as possible. When now looking at the kidney, most of the phosphate regulation happens there. And it's happening along the nephron. And the two decisive factors here are sodium phosphate transporters, NaPi2A, NaPi2C, which are under the regulation of several hormonal systems. And they, by reabsorption or the blocking of reabsorption of phosphate, trigger how much phosphate is excreted and how much is left in the body. And when looking at the list of parameters, the lists are relatively long, but the most important ones are PTH and fibroblast as factors that decrease phosphate absorption. So these factors lead to phosphate excretion, to phosphaturia, and factors that increase phosphate absorption, so taking back the phosphate into the body, especially calcitriol, so active vitamin D plays a role here. And when looking more closely at PTH and FGF23 and on this side, it becomes apparent that both factors actually inhibit the same sodium phosphate transporters, 2A and 2C, but by different intracellular signaling. So indeed, the body uses two powerful hormonal systems to keep phosphate under control. We're now looking more at a systematic and a systemic approach. The usual diets in the world contain 1,200 to 1,800 milligrams of phosphate. And depending on where the phosphate source comes from, if it is, for example, vegetables, it's maybe only 40%. If it's meat, it's 60 to 80%. And if these are phosphate additives, it may even be up to 100% that gets absorbed in the intestines. This is all landing up in a phosphate pool, and this pool should not exceed to serum levels above the normal range. And in order to achieve that, FGF23 is actually released from the osteocytes of the bone, goes to the kidney, inhibits NaPi2A and NaPi2C. PTH does the same purpose. And this is how the body is even controlling phosphate quite potently when kidney function declines. As you can see here in stage 4, stage 5 kidney disease, if patients still have diuresis, up to 500 or 600 milligrams of phosphate per day could be excreted and prevent the early development of hyperphosphatemia. We're now going back from the healthy adult to the situation in, for example, hemodialysis patients who is anuric. This graph shows already a patient who is on a phosphate-restricted diet, only eating about 6,300 milligrams per week. then there are several problems. Problem number one is that due to high or low turnover bone disease, in many instances, less phosphate is buffered by the bone than phosphate is released by the bone. And this is the first of many disbalances. Second, hemodialysis filter is not in the usual dialysis mode of 3 times 4 to 5 hours per week, is only capable to remove about 2,700 milligrams of phosphate per week, which leaves quite a gap to fecal excretion or phosphate restriction. And if then the kidney doesn't produce any urine anymore, there is no phosphate going through the kidneys. And this in a patient on a phosphate restricted diet would already lead to a positive balance of 200 milligrams per week. In case the patient eats a normal diet, this may go up to 2,000 milligrams per week. And this is where we need, for example, phosphate lowering therapies or phosphate binders for. You're all aware that what we are afraid of in terms of hyperphosphatemia is vascular calcification. And vascular calcification can develop in such atherogenic plaques. And this is a bit of a debate whether this kind of calcification is not even stabilizing the plaques. But one can well imagine if such a calcified lesion it picks through the surface of the plaque, this could lead again to a culprit lesion producing thrombosis and closure. What is possibly more important in the chronic kidney disease patients is media sclerosis. So this is not narrowing the vessels, but it's stiffening the vessels. And when the forward directed blood flow goes through these stiffened vessels, it reflects back to the heart prematurely and leads to an invisible pressure load of the left ventricle, which is only reflected by a large blood pressure amplitude, and could certainly develop triggering heart failure and heart failure events. And the way phosphate might cause this deposition in the vessel was always thought now to be an active cellular process, because it seems to be the case that hyperphosphatemia, so an elevated external phosphate, leads to an active uptake of, for example, vascular smooth muscle cells, and to a reprogramming, a transdifferentiation in this regard. So once phosphate levels rise intracellularly, vascular smooth muscle specific genes get downregulated, but osteoblast genes, transcription factors like RUNX2 get upregulated. And that leads to the production of some bone proteins, including osteocalcin, osteopontin, alkaline phosphatase, but also to the production of such calcium phosphate loaded matrix vesicles, which are deposited into the vessel wall and are the initial culprit of vascular calcification. We investigated that some years ago in samples from iliac arteries, which were taken out at the time of kidney transplantation in dialysis patients. And we investigated them by several tools, starting with the micro CT scan. And there you can see a lot of calcified lesions in nearly all the samples we obtained. Some were larger, some were smaller. And as a second step, we looked at it by transmission electron microscopy on an ultrastructural level. And we found all these kind of matrix vesicles, all these structures of all about the same size, composed by a membrane and filled with a material that turned out to be calcium phosphate, or actually more hydroxyapatite. So modeling of these vesicles showed a kind of cell-typical membrane, but the core was composed of phosphate and calcium in the same composition as it is composed in the bone. So this is an ossification of arterial vessels happening predominantly in patients with advanced kidney failure or on dialysis. Now, the regulation happens to start very early, but it also gets to a really pathophysiological range. Here, situations of FGF23 levels are shown. And as healthy individuals with a C-terminal assay, we all should have about values of 30 to 60 for FGF23. Patients with hypophosphatemic rickets, so children which are born with a metabolizing defect of FGF23, may develop levels of up to 600-800, and they have severe hypophosphatemia. And this gets interesting now because with burosumab, there is a humanized antibody for the antagonism of FGF23 on the market, and young patients with this inheritary disease are now treated with this burosumab. There is also the opposite situation. There is an FGF23 loss of function or lack of production problem. And these people or children and youngsters, they already develop calcifications of soft tissues, even of vessels at very young age. So here one can only see how to eliminate the phosphate of the body, and phosphate binders are also a treatment of choice here. Then in CKD, it starts very early in stage, as soon as stage 2, that FGF23 levels start to rise. They extremely rise in dialysis stages, prevalent dialysis, up to 100,000 units per ml can be measured. And then there is this return after transplantation, which can essentially normalize if the transplant kidney develops a completely normal function. So a very interesting time course. When this was all discovered, especially the group of Miles-Wolf thought, well, if there is cardiovascular harm, is it just the phosphate that is causing this? Or is there potential collateral damage by FGF23 directly? And during their work later on, they focused on left ventricular hypertrophy because it was known that FGF receptors are involved, at least in part, in this development of heart hypertrophy. And in this seminal work, they looked at a group of 3,000 patients, CKD patients not on dialysis, measured FGF23 and grouped them into tertiles. What they found was that in the highest tertile of FGF23, patients on average had the lowest ejection fraction, the highest degree of left ventricular mass index, and the highest prevalence of eccentric and especially concentric left ventricular hypertrophy. And they added some in vivo animal experiments here, where they 5-6 nephrectomized rats, which leads to hyperphosphatemia, hyperparathyroidism, hypertension, but also to significant increases in FGF23 levels. And when applying unspecific FGF23 receptor blockers to this experiment, the heart hypertrophy could be nearly completely prevented, despite these animals still had elevated phosphate, elevated PTH, and elevated blood pressure. So very interesting preclinical result and a cause for further research. So the former, but also the current idea is now that the physiological route of FGF23 activates the Klotho FGF receptor 1 co-receptor. It acts on genes regulating mineral metabolism and contributes to phosphorus balance. Excess FGF23 may, however, signal through other FGF receptors, probably especially FGF receptor 4, and this may attract or may have actions on genes regulating cardiac remodeling and lead to left ventricular hypertrophy. And in order to look at FGF23 risk relations, the next or one of the more recent studies is again coming from the CRIC cohort, 4,000 patients with CKD in different stages. And this study looked at individuals who had 5 FGF23 tests over 4 years, or maybe 4 or 3 tests with some modeling upwards. So this was not just a single cross-sectional analysis, but a longitudinal analysis of FGF23 and its action on risk relationships. And what this study found was that there were 3 groups of CKD patients. Group number 1 had relatively low and stable FGF23 levels. Group number 2 had moderately elevated and slowly rising FGF23 levels. And group number 3 had already elevated and rapidly rising FGF levels. And when then looking at the risk prediction for mortality, for general all-cause mortality, the group with a rapidly rising FGF23 levels had a 16-fold risk of all-cause mortality. Those in the intermediate group already a 4-fold risk. And when comparing that, for example, to declining or rapidly declining eGFR, comparing that to stable or elevated and rising blood pressure, or to the phosphate levels itself, this predicted death by several orders of magnitude more potently. And this is one of the studies where people believe that maybe in the upcoming 3-4 years, FGF23 will qualify to become a useful biomarker. Currently, also from the guidelines, this is too premature and too early. Now, what about phosphate and risk prediction? And I think here the best study is still epidemiological observational study, but a study which was at least prospectively designed. It was a pan-European study, and the countries enrolled centers according to the population of the country. So the number was highest here in Germany, lowest in Slovenia, and everything else was in between. And then in each center, 20 patients were randomly identified. That was not by the, let's say, decision of the center physicians. There was a random method to enroll the patients here, and these were observed for 3 consecutive years. And concerning hyperphosphatemia, 2 special results were published. First of all, concerning the use of phosphate binders. So here, in about, I think it was 6,000 or 7,000 patients on phosphate binders versus a little bit more than 1,000 patients not on phosphate binders. Those patients on binders had a much better prognosis concerning all-cause and cardiovascular mortality. And when then looking at additional parameters, it was interesting for me at least to see that this was largely independent on the baseline phosphate levels. So even patients with normal phosphate at baseline had a better prognosis when they were after 3 years or during the 3 years treated with phosphate binders, possibly because that even improved the control to a better level. The second question this study asked was, what is the best phosphate level overall? And what they saw was that levels of 3.6 to 5.2 milligrams per deciliter did not show excess mortality. The absolute best level was 4.4 milligrams per deciliter, so this is exactly this point. And so in the upper normal range. What they additionally did, however, here on the right side, was that they looked at those individuals who had phosphate levels of greater than 5.2 milligrams per deciliter at baseline. And they looked then for 3 years what happened to the phosphate directions. And what they saw here was that if it was possible by whatever means to lower these phosphate levels towards the normal range, mortality decreased and survival improved. So this is one of the best pieces of evidence that phosphate lowering is very valuable. From this, I come to the guideline situation. And as you all know, the Mineral and Bone Disorder Guideline was the second KDIGO guideline that got worked upon and got published in July 2009. So after 5 years, the question was started to be raised whether this needed any revision or update. And finally, the decision to do that was made in 2013-14, and a work group was founded. And this work group had the task to especially look at selected guidelines, because after a so-called controversies conference, especially the red ones were identified as ones that need to be revised because new studies were out. The gray ones, there was also some new information, and also those had to be critically looked at during the guideline process. As you also know, I was given the task together with Mary Leonard to create a small working group. We met twice and had a very busy email and paper and writing exchange. And finally, the publication was in 2017. And I would like to go with you through the calcium and phosphate related results of this procedure. One of the basic results was a new guideline, 4.1.1, which sounds a little bit, I think it sounds reasonable, but unspectacular. But it was important to the working group to stress and emphasize that we should always look at phosphate, calcium, and PTH as the key biomarkers together, and not just picking one of them and changing it, because that would not be just for the possible therapies. There are any of the therapeutic options always influence all three of them. The second point was that it was taken out that hyperphosphatemia should be treated preventively. Hyperphosphatemia must and should be treated, but normal phosphatemia should not already be addressed. And I will now tell you the 3 or 2 studies that paved the way for these guidelines. First of all, the combination of parameters, and there a publication by Geoff Block was very important, who grouped PTH, calcium, and phosphate based on the 2009 guidelines on high, target, and low levels. And he created all these possible combinations of high, high, high to low, low, low. And interestingly, for example, for hyperparathyroidism and PTH levels above around 500 to 600 picograms per ml, it was interesting that this turned out to be a very significant risk factor if calcium and or phosphate were also pretty high. However, in a situation where calcium and phosphate were under control, even these very high PTH levels did not predict mortality. Okay. I was interrupted, I guess. Is that possible?
Yes, I think.
So we also grouped them for the PTH calcium phosphate for the low to high combinations. And we got three special messages here. Number one, again, high phosphate was always connected to high mortality and high risk phenotypes. The second one was also high calcium, which was, however, much less frequently observed, was connected to the high risk phenotypes. The third one I did not put up was surprisingly low PTH levels. So PTH levels of below 130 in high hemodialysis patients were also a risk factor in this 36,000 patient cohort. Concerning the preventive approach of hyperphosphatemia, this goes back to this study by Geoff Block and others. And here, 128 patients with a GFR of 20 to 40 mils per minute with phosphate levels in the upper normal range were recruited. And in the one group, they were treated with 3 phosphate binders, 1/3 of the group with each of them. And this was compared to a 4th group of placebo. And the change in mean phosphorus from baseline to the average of 3, 6, and 9 months was investigated. Top-line results from this was, on the one hand, that it was possible to lower the phosphate significantly, but it was difficult to lower it into the lower normal range. But which was something that was quite unexpected was that this did not influence calcium calcification levels. So for lanthanum and sevelamer, it was not significant. For the calcium-containing phosphate binders, there was even an increased risk of coronary artery calcification on calcium acetate in this preventive cohort. And based on this study, the decision was made not to treat hyperphosphatemia before it occurs. Concerning, again, the use of phosphate binders, in the previous guideline, there was already the recommendation to restrict the dose of calcium-based binders. But especially in the situation of hypercalcemia, of vascular calcification, dynamic bone disease, and PTH levels. And just these qualifiers were taken out. And now, independent on the situation where the patient developed hyperphosphatemia, there was a general aid to or suggestion to restrict. And this was based on especially 2 studies from Italy, one in hemodialysis patients, where in this case a calcium-free binder, sevelamer, was compared to calcium-based binders. And this had especially an impact on cardiovascular endpoints, arrhythmias, and cardiovascular mortality. And second, in CKD patients not on dialysis, 212 patients, where there was even an impact observed favoring survival in a calcium-free phosphate binder treatment, and maybe a first hint, which was not significant though, to delay the start of dialysis. And in one out of several meta-analysis, there was also an up to 46% improved survival or mortality risk reduction if patients were kept more on calcium-free binders. Nevertheless, restriction was favored and not the term avoid, because in all these studies, very high doses of calcium-based binders were used in a competitive manner. And second, one must be aware, of course, that in parts of the world, the access to calcium-free binders is sometimes limited either due to availability or due to the costs of the treatment. And so restriction was found to be the appropriate term here. Concerning calcium management, in the previous guideline, 2009, it was still the recommendation to maintain the calcium in the normal range. The new guidelines only commented on avoiding hypercalcemia. And the term hypocalcemia was a little bit left open for the treating physician. And this went back to the EVOLVE study. You know, this study studied Cinacalcet versus placebo on cardiovascular and mortality endpoints and did not show a significant advantage of Cinacalcet in the intention to treat analysis, at least. Nevertheless, here are the biochemical parameters. And first of all, you see there was a distinction, of course, in the PDH levels, about 500 to 600 in the placebo group, and nearly 300 in the Cinacalcet group, and actually no mortality difference between these PTH levels. That has to be commented. Phosphate differed in the beginning in favor of Cinacalcet, but then over the years it came back together. But as you know, the mode of action of calcium mimetics implement hypocalcemia, which is not transient, which goes on for years under this treatment. And actually, many patients here were hypocalcemic when Cinacalcet treatment was done to treat hyperparathyroidism. And in this study, no excess mortality was found in these hypocalcemic patients induced at least by Cinacalcet. And so the work group emphasized that hypocalcemia should be approached individually, and mild and asymptomatic hypocalcemia, and especially in the context of calcium mimetic treatment, can be tolerated, especially in order to avoid an inappropriate calcium loading in adult dialysis patients. Now, a few words to two new substances in this regard. And one is, or newer substances, one that has become available only a few years ago in Germany is saccharoferric oxyhydroxide, which is an iron-based binder. The other iron-based binder, iron citrate, never made it to Europe, but this one made it to Europe quite well. And actually, this composition of iron saccharose starch complex leads to a very tight iron fitting into this molecule and a limited iron release from here. And I was also really taking part in the pivotal trials of this study. And the key trial was the PACL05A stage 1 trial, in which after a washout of hyperphosphatemic patients, PA21 at that time, the saccharoferric oxyhydroxide, was competitively compared to sevelamer carbonate over a 6-month period. The key analysis was then to maintain the patients on PA21 versus another group where patients were led back to a very low dose exposure of PA21 in order to look whether hyperphosphatemia redeveloped. Then a long-term safety and efficacy trial was added. And so for another year, patients coming from this arm and from this arm were led into a follow-up open label study to collect safety data especially. The first safety analysis was then at week 24. The primary efficacy was coming from these subgroups of patients. And the secondary efficacy was a direct comparison of PA21 to sevelamer carbonate under these treatment conditions. So a little bit complicated design, but I think it's pretty straightforward when you look at the data. So in this 4-week study, those patients who were taken again then on a very low dose of the compound, they redeveloped quite significant hyperphosphatemia. Those patients who were stable for half a year on sucroferric oxyhydroxide, they were also stable with phosphate control. Comparing sevelamer and sucroferric oxyhydroxide, after 12 weeks, they were comparably efficacious. One thing that was particular here was that the PaO21 group was only started on 2 tablets per day, so only 2 meals were covered with a phosphate binder, while sevelamer was started with 3. So it took a little bit longer to reach the efficacy phase, probably. When then looking at the long-term extension, so the second part of the curve, PA21 even kind of overtook for sevelamer for this remainder of the study, and no additional safety signals were coming from this observation, and efficacy was pretty good. One of the major advantages of PA21 versus many other phosphate binders is the low pill burden. I said that it was started the study with only 2 pills per day, and after the first 6 months, it remained only at 3 pills per day, while it was necessary to take 8 pills of sevelamer to show a comparable effect in this trial. Concerning iron release and absorption, there is not much concern. There was a very tiny increase in transferrin saturation over the course of disease, which did not lead to hemoglobin changes of significant nature. This is much different in the iron citrate, which is not available in Europe. This may be in CKD patients not on dialysis even a small advantage, but it may also lead to a concurrent iron accumulation. So it's a little bit difficult how to rate this observation. And I think I have no experience here. I'm not sure whether this will reach the European market at all. One area, of course, that has to be discussed is safety of these drugs, and there were some differences. Sevelamer had some of the known gastrointestinal side effects, which was more nausea, vomiting, constipation. But PA21 had a double high rate of diarrhea in these patients. And I come to that in a minute. The feces discoloration was only reported by 16%. This is interesting because only 1 tablet of the compound blackens the stool for 3 or 4 days. I know many researchers who took that probe, and so it's interesting that only 16% reported that. Anyway, concerning the diarrhea, which was mostly mild to moderate, only 1 patient actually who developed here severe diarrhea. It happened in the start of the treatment, in the beginning of the treatment. And it usually fades away then after time. After half a year, there's hardly anything observed like that. What I do when I treat these patients is I never start with 3 pills a day. I do it in a way like the study does it. Treat sometimes even only with 1 pill to the largest meal, because then the diarrhea, if it comes, is only very mild, and you can increase and adapt the dose, and the patient will not lose the trust in you and your practice. And after that, if you are at 3 pills per day, this is one of the most powerful phosphate binders I've been working with in my clinical practice so far. Now, a few more additional observations. FGF23 was also measured in these studies, and this obviously phosphate binding leads to lowering of FGF23 levels that was not distinct between the two compounds under investigation here. Interestingly, after a year, there was some difference in the PTH levels. So there was a lowering, or a more active lowering in the PA21 arm than in the sevelamer arm, and I will come to that in a minute again. TRPV and a bone alkaline phosphatase as two biomarkers of bone turnover, they were not changed or were not different between the two compounds. Concerning PTH levels, there was a subgroup analysis done where oral active vitamin D versus IV active vitamin D treatment was compared. And actually, with the IV active vitamin D compound, there was not a large difference, only after 24 weeks, still in favor of PA21. But there was kind of an opposite effect on PTH levels in patients who were on oral active vitamin D treatment. And this is suggestive that the sevelamer might bind part of these oral active vitamin D compounds, thus leading by the same dose to a lesser absorption of those compounds, and thus favoring the development or redevelopment in a way of higher PTH levels. So in this regard, concerning the available phosphate binders, Jürgen Flöge from Aachen made a summary in the Journal of Nephrology just 4 or 5 years ago and listed all the available ones on a global level. And actually, of course, all of them are effective. Colestylan was taken out here because it was not more available, at least on the German and European market. Concerning the pill burden, there are only 3 compounds that are characterized by a low burden, which is aluminum, and which should probably be avoided now and in the future, and the sucroferric oxyhydroxide. Pleiotropic effects may be associated with sevelamer, especially lowering the cholesterol levels, lowering uric acid levels, maybe even some effects on inflammation, but also maybe some interactions with medications people get. Accumulation, certainly positive for aluminum and calcium. Some have been shown for lanthanum, possibly. Ferric citrate enters the body quite effectively, and this iron does not enter the body. But then we still have the costs, and some of the binders have quite low costs, others are of higher costs. But of course, efficacy and safety need to be regarded at first instance. A couple of more slides to a study that I was also part of, and that is now in press. And what we did here is we treated hemodialysis patients who were already on phosphate binders, but where the phosphate binder treatment was not taking the phosphate levels on target. And these were then additionally treated. So add-on treatment with a modified release nicotinamide, which was only taken 1 a day at night, not to any meal or to each meal. And it was compared to placebo. And here this graphical abstract shows phosphate was lowered. Actually, as a secondary endpoint, IPTH was lowered, and the T50, which is the time of serum-induced calcification, was increased. So there was a favor concerning a calcification systematic protection, possibly. On the safety side, there was also, this is also a substance is associated with mild to moderate diarrhea, with
يا مصطفى انقطع كلام الرجل المرة الثانية.
Most likely his connection, there is a problem with his connection.
Mustafa, can you fix it?
I'm sorry, I got dropped again, but I returned. I will open once more. This is a slide I was on, is that right?
Yes, sir.
Yes,
it is.
Absolutely.
It is.
Okay. So looking at several instances here, so patients' response, there was the target range of phosphate was achieved in 31 versus 20% with a nicotinamide. The lowering into the normal range, 24 versus 14%, below 5.5, 50 versus 38%, an improvement by more than 0.6 milligrams per deciliter, 44 versus 30%. And risk reductions were also quite interesting. So this paper should be out in a couple of days or few weeks. So finally, a look back to the key messages of KDIGO, and this is my last slide in this instance. It is, first message from my point of view, it is important to emphasize the interdependency of serum calcium, phosphate, and PTH for clinical therapeutic decision-making in all treatments of hyperphosphatemia, of hyperparathyroidism. Targeting hyperphosphatemia is still considered as a mainstay of current CKD-MBD management, and new evidence suggests that excess exposure to exogenous calcium in adults may be harmful in all stages of CKD, regardless of other risk markers. So I'm ready with that, and I will stop my presentation here, and I'll be back for questions and answers if you have some for me.
Thank you, Professor Marcus, for very informative presentations about the mineral-borne disorders. Yes, I think we have few questions. We can take maybe 2 or 3. One of the questions regarding, is there any difference between hemodialysis and peritoneal dialysis regarding the use of the phosphate binders BA21?
No, it's not. Actually, this study was one of the few phosphate binder studies that explicitly included PD cohort, which was significant and which was also separately published. So there was no efficacy or safety difference with regard to peritoneal dialysis.
Second questions regarding the same questions for chronic kidney disease stage 2, 3. I mean pre-dialysis. Is the use of BA21 is approved to be in chronic kidney disease stage 3, 4, or should be on dialysis?
I believe that it's not officially approved. It's an off-label as far as I know, at least in Europe or Germany. There were hardly any systematic studies here. In Germany, it's not a big deal to use them in this instance. If patients have hyperphosphatemia, we are usually not taken into any regress or questioning, but this may be different in other countries. But I think the official label is not containing CKD 3 or 4.
Maybe the last question related to this new products. I'm not sure if it is available in Saudi Arabia. I don't know, maybe Professor Mitwalli, he can help us. Is it available in Saudi Arabia or still under investigations?
As far as I know, it's still not available, but maybe still needs the approval of Saudi FDA. Did you hear me, Fuad?
Yes. Thank you, Prof. Thank you, Prof. We received a lot of questions related to the use of the availability of these medications. Okay. Maybe I will take one. Is there any role for using both 1-alpha vitamin D in patient with high BTH and low vitamin D? 1-alpha vitamin D and vitamin D.
Yeah, we are, Germany is a very 1-alpha friendly country. This is probably the most frequently prescribed active vitamin D compound. And if patients have significantly elevated PTH levels, and if calcium and phosphate are more or less under control, this is quite frequently used. We usually, or many of German and European nephrologists, use additionally native vitamin D for supplementation, because it is thought that at least a severe 25-OHD deficiency could also have negative effects on other functions than the bone. For example, immune system and heart and so on. So we relatively frequently prescribe both active, and 1-alpha then is the marked leader currently in Germany, and added with, let's say, about 1,000 or 2,000 dose equivalent units of vitamin D3.
By the way, somebody just told me now it is available. The drug is available in Saudi Arabia.
Okay.
The drug representative told us this.
Okay, but very good news. Actually, we need maybe more experience in how to use it in chronic kidney disease and dialysis patients. In our hospital, we don't have it. Still now, we don't have it actually. Okay. Thank you, Dr. Professor Marcus, for the very nice update on the mineral bone disorders and in chronic kidney disease. I will leave the mic for Professor Mitwalli for the final comments.
Thank you, Professor. Thank you, Dr. Shaibi, for your contribution. And I have to thank the Pharmaceutical for their continuous support for the society. I thank them again and again. And I just want to ask Professor if it's available and if it's okay with him, we can post his presentation on our site. We'll be very thankful to him. And is that okay with you, Prof?
Yes, okay. There are no unpublished data, so I don't think there is any problem here. So please use it. It's an honor for me.
Thank you, sir. And also I want to thank everybody. I think we have over 2,500 participants tonight with us. Wow. And I want to remind them that we have another webinars on the 24th of March, sponsored by the Baxter company. It's going to be extended hemodialysis, and I hope everybody will be there. At the end, I have to thank both Professor and Professor Kellis and Dr. Fahad for their help and their contribution. And I don't know if Khalid wants to make any comment.
No, absolutely no. Thank you very much, and have a nice night, inshallah, for everybody. Thank you very much.
Thank you, so Professor. Much. Hope to see you soon in Saudi Arabia.
Hope to
or
see
in
you
Germany
again.
for that matter. Bye-bye.
Bye-bye.
Thank you very much.
Goodbye.
Shukran, Fuad. Thank you very much. Thank you.